Hi, my name is Laura, and welcome to my audio version of the Family Medicine Infectious Disease EOR Study Guide. The rest of the family medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA infectious disease portion of the family medicine end of rotation exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. Let's start off easy with the flu. This is an acute respiratory illness caused by influenza A or B. Flu is spread by airborne respiratory droplets, most commonly in the fall and winter months, and influenza A is associated with more severe infection. Patients present with an abrupt onset of fever, chills, myalgias, headache, upper respiratory symptoms, and malaise. Diagnosis is usually clinical, but a rapid antigen test can be done by a nasal swab. Treatment is largely supportive, like NSAIDs and rest. Antiviral medications are an option for patients with high risk of complications, but must be initiated within 48 hours of symptom onset to be effective. Antivirals that work against influenza A and B are oseltamivir, which is Tamiflu, zanamivir, and ribavirin. Antivirals that only work against influenza A are amantadine and rimantadine, but these are not commonly used due to widespread resistance. Flu can also be prevented by an annual vaccine, which is recommended in everyone 6 months or older. Another common infection is mononucleosis, commonly referred to as mono or the kissing disease, because it's transmitted via saliva. It's especially common in young adults and teenagers. About 90% of mono illness is caused by the Epstein-Barr virus, and the other 10% is caused by cytomegalovirus or CMV. We'll focus on Epstein-Barr in this section. Mono symptoms typically include fever, pharyngitis or sore throat, posterior cervical lymphadenopathy, splenomegaly, malaise, and myalgias. Additionally, a maculopapular rash develops in most mono patients who are treated with ampicillin or amoxicillin, like for the pharyngitis, since strep throat and mono can coexist, so don't prescribe those here. Diagnosis is made by a positive heterophile antibody screen, which is called a monospot test, and a peripheral blood smear will show more than 10% atypical lymphocytes with enlarged nuclei. Liver function tests might be increased as well. Treatment is mostly supportive: rest, analgesics, and antipyretics, and symptoms can last for months. Corticosteroids are only used if there is concern for airway obstruction due to the lymphadenopathy. It's also important to have the patient avoid contact sports for 1 month due to the risk of splenic rupture. Lastly, a note about the actual Epstein-Barr virus. It infects B cells and is associated with Hodgkin lymphoma. It can also cause Burkitt's lymphoma, and in AIDS patients, it can cause CNS lymphoma. The next topic is HIV and AIDS. Human immunodeficiency virus, or HIV, is a retrovirus, meaning it changes viral RNA into DNA using reverse transcriptase. There are 2 types: HIV-1, which is more common, and HIV-2. It is transmitted through sexual intercourse, sharing needles for IV drug use, transmission from mother to child during birth or breastfeeding, needle stick injuries, and mucosal contact with infected blood. It was also transmitted by receipt of blood products prior to 1985, which is the year that the FDA approved the first test to screen donor blood for HIV. There are 3 stages of HIV infection: acute, chronic, and acquired immunodeficiency syndrome, or AIDS. In the acute stage, which occurs within a few weeks of exposure, patients might experience a flu-like illness with fever, malaise, generalized rash, and generalized lymphadenopathy. In the chronic stage, patients can be asymptomatic or have symptoms of varying severity, depending on how advanced the infection is. This stage can last for years. The third stage, AIDS, is defined as a CD4 count below 200 or the development of an AIDS-defining illness. This stage can present with recurrent and severe opportunistic infections that become life-threatening. HIV wasting syndrome, which is chronic diarrhea and weight loss, can occur, as well as AIDS-associated neurologic changes, like dementia or encephalopathy. Diagnosis is made with an antibody test. ELISA is used as a screening test, and if it's reactive, then confirmation is made by Western blot. These tests are usually accurate, meaning they'll be reactive within 3 to 6 months of HIV exposure. There's also rapid testing that can be done with blood or saliva, but a confirmatory test is also needed if it's positive. Diagnosis can also be made by HIV RNA viral load, which can be positive in the window period, but is more often used to monitor treatment effectiveness and infectivity in patients that are already diagnosed with HIV. Treatment of HIV used to start at CD4 levels of 350 or below, but recent guidelines now strongly recommend initiating antiretroviral therapy in all patients regardless of CD4 levels. Treatment does not eradicate or cure HIV, but it can decrease viral load, delay the onset of AIDS, increase the time to development of opportunistic infections, prolong survival and reduce HIV-related morbidity, and prevent transmission. Antiretroviral therapy, or ART, also called HAART, H-A-A-R-T, consists of a combination of two nucleoside reverse transcriptase inhibitors, or NRTIs, plus another drug. That third drug can be a non-nucleoside reverse transcriptase inhibitor, NNRTI, a protease inhibitor, or an integrase inhibitor. NRTIs work by inhibiting viral replication, by inhibiting HIV viral RNA-dependent DNA polymerase. Patients are typically prescribed 2 of these in a standard ART regimen, so combination tablets are common, like Truvada. Side effects of NRTIs can include peripheral neuropathy, pancreatitis, and hepatitis. NNRTIs have a similar mechanism of action, but the most common side effect is a rash. Protease inhibitors inhibit HIV protease, which causes production of non-infectious HIV particles, and most protease inhibitors can be remembered with the suffix -navir, like ritonavir. Side effects include nausea, vomiting, diarrhea, lipodystrophy, and hyperlipidemia. Integrase inhibitors inhibit the insertion of a DNA copy of the viral genome into the host DNA. These can be remembered with the suffix tegravir, like raltegravir. Side effects can include hyperlipidemia, nausea, vomiting, diarrhea, headache, and hyperglycemia. And again, a standard antiretroviral therapy regimen consists of 2 NRTIs plus either an NNRTI, a protease inhibitor, or an integrase inhibitor. There is also post-exposure prophylaxis in the event of something like a needle stick or sexual assault. This typically consists of the combination drug Truvada, which contains 2 NRTIs, plus an integrase inhibitor like raltegravir. Post-exposure prophylaxis should be started within 72 hours of exposure and continued for 4 weeks. There's pre-exposure prophylaxis as well, called PrEP, to reduce the risk of HIV in at-risk patients who are currently HIV negative. Truvada is the most commonly prescribed medication for this. It reduces the risk of getting HIV from sex by about 99% and reduces the risk of HIV from IV drug use by about 74%. The last thing we have to go over here is treatment of the opportunistic infections. As HIV progresses and CD4 count decreases, the patient's immune response gets weaker, making them more prone to infections. A CD4 count of 700 to 1500 is considered normal. At CD4 levels of 200 to 500, patients are at risk for Kaposi sarcoma, tuberculosis, bacterial pneumonia, herpes zoster, lymphoma, thrush, herpes simplex virus, and coccidioidomycosis. Those with a CD4 count below 200 are considered to have developed AIDS and are required to get prophylactic treatment for a variety of opportunistic infections. At CD4 levels below 200, patients are at risk for pneumocystis. First-line prophylaxis for pneumocystis is Bactrim. At CD4 levels below 150, some patients are at risk for histoplasmosis. First-line prophylaxis for histoplasmosis is itraconazole. At CD4 levels below 100, patients are at risk for toxoplasmosis and cryptococcus. First-line prophylaxis for toxoplasmosis is Bactrim, and prophylaxis for cryptococcus is fluconazole. At CD4 levels below 50, patients are at risk for Mycobacterium avian complex and cytomegalovirus retinitis. First-line prophylaxis for Mycobacterium avium complex is azithromycin or clarithromycin, and prophylaxis for CMV retinitis is valganciclovir. The next topic is meningitis, which is an infection of the meninges. This is divided into bacterial meningitis and aseptic meningitis, which includes viral and fungal etiologies. Let's start with bacterial meningitis. Clinically, these patients will present with fever, chills, and meningeal symptoms, often a headache, nuchal rigidity or stiff neck, photosensitivity, nausea and vomiting, and sometimes altered mental status or seizures. Koenig's sign and Brudzinski's sign are buzzwords here because even though they're not that common, if they're present, they're very specific for meningitis. A positive Koenig's sign is the inability to straighten the knee without causing pain. So Koenig can't straighten knee, causes pain. Koenig. And a positive Brudzinski's sign is when flexion of the neck causes hip or knee bending. Brudzinski's bending. Now diagnosis. While a head CT is often done first, definitive diagnosis of meningitis is made by lumbar puncture and CSF examination. However, do not wait for lumbar puncture results to start empiric antibiotics if a bacterial meningitis is suspected, since early antibiotics have been shown to increase survival rates. Bacterial meningitis has common pathogens and empiric antibiotic treatment algorithms that are based on age group, so let's go through those. In newborns who are less than a month old, the most common pathogen is group B strep. Other pathogens include Listeria monocytogenes, E. coli, and strep pneumonia. In this age group, empiric treatment is ampicillin for the Listeria, plus a third-generation cephalosporin, or an aminoglycoside. In patients aged 1 month through 18 years, the most common pathogen is Neisseria meningitidis, which is associated with a petechial rash. Other pathogens include strep pneumonia and Haemophilus influenza. In this age group, empiric treatment is a third-generation cephalosporin plus vancomycin. In patients aged 18 through 50 years, the most common pathogen is strep pneumonia, but Neisseria meningitidis is also common. Other pathogens include Haemophilus influenza, Listeria monocytogenes, and gram-negative rods. The empiric treatment in this group is the same as the last group, a third-generation cephalosporin plus vancomycin. In patients older than 50, the most common pathogens are strep pneumonia, Listeria monocytogenes, and gram-negative rods. In this group, empiric treatment is ampicillin, again for the Listeria coverage, plus a third-generation cephalosporin, plus or minus vancomycin. All right, that was a lot, so let's just recap. In neonates less than a month old, group B strep is most common, and they get ampicillin plus a third-generation cephalosporin. In kids 1 month through 18 years old, Neisseria meningitidis is most common, and they get a third-generation cephalosporin plus vanc. In patients 18 through 50 years old, strep pneumonia is most common, and they get a third-generation cephalosporin plus vanc as well. In adults over 50, strep pneumonia is most common, and they get ampicillin plus a third-generation cephalosporin plus or minus vanc. Okay, we're almost done, but 2 more drugs to know. Dexamethasone is recommended to reduce the risk of neurologic complications, especially if strep pneumonia is known or suspected. And if exposed to meningitis, ciprofloxacin can be given for post-exposure prophylaxis. So as we said, a lumbar puncture with CSF analysis is the definitive diagnosis. The CSF analysis can also differentiate between bacterial, viral, and fungal etiologies. In bacterial meningitis, the opening pressure will be increased and the CSF will appear cloudy. It will also have high protein and low glucose levels. And white blood cell count will be very high with a predominance of neutrophils. Now let's move on to aseptic meningitis, specifically viral meningitis. Clinically, this presents with headache, fever, mild confusion, and meningeal symptoms like nuchal rigidity, positive Brudzinski's and Koenig's sign, photophobia, and lethargy. And these symptoms are not as severe as bacterial meningitis. The most common culprit is the enterovirus family, but other causes include arboviruses, herpes simplex virus 1 and 2, mumps, and HIV. For diagnosis, a head CT might be done first, but again, a lumbar puncture and CSF analysis are the definitive diagnosis, and can differentiate between bacterial and viral etiologies if it's unclear. In viral meningitis, the opening pressure is normal or slightly increased, and the CSF will appear clear. It will also have a normal or slightly increased protein and a normal glucose level. And the white blood cell count will be high with a predominance of lymphocytes. Treatment for viral meningitis is mostly supportive with antipyretics, fluids, and antiemetics. Viral meningitis is usually self-limited and has a good prognosis. So, a quick review on the differences between bacterial and viral meningitis on a CSF analysis. Bacterial meningitis has cloudy CSF fluid with a significantly increased white blood cell count that shows mostly neutrophils. In contrast, viral meningitis has clear CSF fluid with an increased white blood cell count that shows mostly lymphocytes. Bacterial meningitis has significantly decreased glucose and very high protein, while viral meningitis has normal glucose and normal or slightly increased protein. So basically, if the glucose is normal, suspect viral meningitis. And if the white blood cells are predominantly neutrophils, suspect bacterial meningitis. Next is Lyme disease. Lyme disease is caused by the gram-negative spirochete, Borrelia burgdorferi, which is spread by the Ixodes tick, or the deer tick. Cases are most common in the spring and summer and are more common in the Northeast, Midwest, and Mid-Atlantic regions. Transmission is more likely if the tick appears engorged or has been attached for 72 hours or more. Clinical manifestations of Lyme disease can be divided into 3 stages: early localized, early disseminated, and late disease. Early localized infection often presents with erythema migrans, which is that erythematous bullseye rash with central clearing. It appears within a month of the tick bite and expands slowly over days to weeks in the same area as the bite. This erythema migrans might be accompanied by headaches, fever, malaise, or lymphadenopathy. Early disseminated Lyme disease occurs 1 to 12 weeks after the tick bite and is characterized by rheumatologic, neurologic, and cardiac symptoms, as well as multiple erythema migrans lesions. So symptoms include arthritis, especially of large joints, headache, meningitis, cranial nerve palsies, neuropathy, AV heart block, and pericarditis. And finally, late disease is characterized by persistent synovitis, persistent neurologic symptoms, and subacute encephalitis. Diagnosis is made clinically in early Lyme disease based on a history of tick bite and presence of erythema migrans and arthritis. This is because serologic testing will not be positive until later in the disease, around 3 weeks. Serologic testing involves ELISA testing, followed by a Western blot for confirmation if the ELISA is positive or equivocal. Treatment in early disease is doxycycline, which is first line, but amoxicillin is the treatment of choice in children and pregnant patients since doxy is contraindicated. In late or severe disease, ceftriaxone is indicated. And lastly, in areas where there's a high percentage of infected ticks, doxycycline can be given prophylactically within 72 hours of deer tick removal if the tick was present for more than 36 hours. Salmonella is one of the causes of invasive infectious diarrhea. Other causes include Shigella, which we'll go over next, Campylobacter, Yersinia, and enterohemorrhagic E. coli. Symptoms of infectious diarrhea include high fever, fecal blood, and fecal leukocytes. The most common sources of Salmonella are contaminated food and water, and infection is by fecal-oral route. Diagnosis is made by cultures of blood, stool, and urine. There are different types of Salmonella, but they can broadly be grouped into those that cause gastroenteritis and those that cause typhoid fever or enteric fever. Gastroenteritis is primarily caused by Salmonella typhimurium and results in abdominal pain, fever, cramping, vomiting, mucus, and bloody diarrhea. It's unpleasant but usually self-limiting. Typhoid fever, on the other hand, is much more severe and is primarily caused by Salmonella typhi. This infection is characterized by an intractable fever for weeks or months, headache, pharyngitis, pea soup diarrhea with a brown-green color, abdominal cramping, relative bradycardia, hepatosplenomegaly, and rose spots or blanching papules on the trunk that appear around the second week. Typhoid fever is uncommon in the US, but much more common in the developing world. And after recovering from the disease, about 1 in 20 people can actually become chronic asymptomatic carriers and pass it on to others. You might have heard of Typhoid Mary. She was a carrier who was supposedly responsible for multiple outbreaks of typhoid fever in New York City in the early 1900s. Her real name is Mary Mallon, and she worked as a cook, but due to poor hand washing and just general lack of knowledge about the disease, she was determined to have spread it to over 50 people, with at least 3 resulting deaths. In fact, Mary did not believe authorities when they told her she was spreading the disease, since she had no symptoms, so she evaded them for years, changed her name, changed jobs several times, and kept working as a cook, until she was eventually caught and forced to quarantine on North Brother Island. Fortunately, now we have typhoid conjugate vaccines and antibiotics and safe hand washing and food handling procedures. All right, back to the gastroenteritis type of Salmonella. Treatment consists of fluids and supportive care, and if it's severe, you can give fluoroquinolone, ceftriaxone, and Bactrim. But don't give anti-motility drugs with invasive diarrhea because it can cause toxicity. The last topic is Shigella, another cause of invasive infectious diarrhea. Shigellosis can progress to dysentery, which is when the infection causes inflammation of the colon and leads to the frequent and painful passage of small amounts of stool that contain blood, pus, and mucus. Other symptoms of Shigella include lower abdominal pain, high fever, tenesmus, explosive watery diarrhea, and dehydration. Complications can include toxic megacolon and reactive arthritis, and febrile seizures can occur in children. Shigella is a gram-negative bacterium that is highly virulent and transmitted by fecal-oral contamination. In the U.S., it predominantly affects children and spreads in crowded places like daycares. Diagnosis is made by stool cultures, which will show Shigella species, leukocytes, and red blood cells. Also, a sigmoidoscopy might show areas of ulceration. Treatment is fluids and supportive care. If the infection is severe, you can give Bactrim or ciprofloxacin. And that wraps up the infectious disease portion of the Family Medicine EOR Exam Study Guide. If you're listening to these videos in order, the next section is urgent care, which I'll link below once it's up. If you're listening as these videos roll out, there's a whole lot of EOR content getting uploaded at once. So stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.